No le veo countdown, no está pasando. Ya. Welcome everyone to our webinar series. Today we have Professor Gonzalo Alarcón with us to present indications and interpretation of intracranial recordings in epilepsy. Professor Alarcón was born in Madrid, where he graduated in medicine and obtained a PhD at the University Complutense, Madrid, Spain, both with distinction. In 1987, he obtained a Fleming Award to carry out research on spinal processing of pain in the Department of Physiology of the University of Bristol, UK. He then specialized in clinical neurophysiology in the UK. Over the last 30 years, his clinical practice has included adults and children and has focused on electroencephalography, presurgical assessment of epilepsy, telemetry, intracranial recordings, and intraoperative electrocorticography. Such clinical practice has provided the basis for research on several aspects of epileptology at Imperial College, Universidad Complutense Madrid, King's College London, and Hamad Medical Corporation, Qatar, with particular interest in presurgical assessment of epilepsy and the mechanisms involved in the generation and propagation of human epileptiform discharges and seizures. Some of the research techniques developed by his group have translated into clinical useful tests like single pulse electrical stimulation and discharge latency analysis. In 1994, he was awarded the Gowers Prize as a young physician by the International League Against Epilepsy, British branch. He has run the MSc course in epilepsy at King's College London from 1995 until 2015, and he is a lead editor of the epilepsy volume of the Oxford Specialist Handbooks in Neurology and Introduction to Epilepsy by Cambridge University Press. He has over 300 publications in the field of EEG and epilepsy, including over 100 peer-reviewed original research papers. He has been a consultant in clinical neurophysiology at King's College Hospital from 1996 to 2015 and reader at the Institute of Psychiatry from 20 until 2015. In October 2015, he moved to Doha, Qatar as a senior consultant epileptologist for Hamad Medical Corporation. He was appointed professor of neurology at Weill Cornell Medical College in 2017. The learning objectives for today are: recognize and describe ictal and interictal patterns with intracranial recordings. Recognize the different types of EEG recordings and methodologies, example, invasive, scalp, stereo, and video EEG. Thank you very much, Professor Alarcón, for being with us today. We welcome you to this webinar.
Thank you very much, and good evening to everybody. Thank you very much for inviting me to talk about this fascinating topic. My professional activity for many years. I have no conflict of interest on this talk, and just to center the talk on epilepsy surgery, just to say, of course, that epilepsy is a very common neurological condition, and the first choice of treatment management is medical treatment, of course, but about 30% of patients are not controlled by medicines, and therefore they are suitable to be assessed for epilepsy surgery. And the main bulk of epilepsy surgery at the moment is still resective surgery, and that consists of removal of the epileptogenic zone, which is originating the focal seizures, and that can render seizure free somewhere between 30 and 60% of patients, depending on the type of epilepsy and the complexity of it. Now, the interesting thing about epilepsy surgery is that it's based on cortex, which is not only structurally abnormal, but also functionally abnormal. And therefore, we need to use both structural and functional methods to identify the area that is abnormal, because, of course, the semiology of epilepsy is functional, even though the underlying cause might be structural. So that means we have a very wide variety of tests that we can and we should use, going from the detailed medical history up to more sophisticated tests, through sophisticated neuroimaging, scalp EEG, ictal and interictal, neuropsychiatry and neuropsychology. Some centers use magnetoencephalography. And when all these non-invasive methods are not congruent, then we need to use more invasive techniques sometimes, which are intracranial electrodes, implantation of intracranial electrodes to record directly from the cortex. So the purpose, of course, is to operate the patient and render the patient seizure free. But it's been notoriously difficult to predict surgical outcome. Engel in 1993, before that actually, he designed a scale to measure surgical outcome, and based on 4 grades that we will be using throughout the talk. One is essentially seizure free or nearly seizure free. This number 2 is rare seizures, disabling seizures, maybe 1 or 2 a year, and then 3 is some improvement, still with a lot of seizures, and 4 is no improvement. So we usually consider either 1 or 1 and 2 as favorable outcome, and these 2 as poor outcome from surgery. Now, there's been a number of factors that the prognostic factors that have been described in the literature, trying to predict the outcome of surgery. But overall, we want to summarize essentially those patients. Many reports suggest that those patients with a lesion on MRI do better than those without. And therefore, because those patients without lesions on MRI, normal MRI, have to go through intracranial electrodes, then in some series, those who undergo intracranial recordings do worse than those who don't. But that I didn't find in our practice that was the case, and we looked at it in some more detail and separated the patients into temporal and frontal patients. And we found that in temporal patients, the temporal patients tend to do well, regardless of whether the MRI is normal or not, or whether we require intracranial electrodes or not to assess them. And in patients with frontal seizures, those who have a normal MRI, this 33%, tend to do worse. And that, if you think about it, is logical because most of the resective temporal surgery is temporal lobectomy. And in temporal lobectomy, of course, you will resect neocortex, but also the hippocampus, which is the source of seizures in about 80% of patients with temporal lobe epilepsy. So the most likely candidate, the hippocampus, is always removed in temporal lobe surgery. But frontal surgery is more complicated because the frontal lobe is bigger, so you can't remove it all. And there is no a priori candidate that originates seizures in 80% of patients. So you need some other strong indication of where the epileptogenic zone is in frontal lobe epilepsy. And that often is a lesion. So I think that's probably the bottom of the question, which is that those patients with normal MRI and frontal lobe epilepsy do tend to do worse. But in temporal lobe epilepsy, that's not necessarily the case. You can operate patients with temporal lobe epilepsy with intracranial recordings and do well, even if MRI is normal. So summary of indications of intracranial recordings, essentially two: localization of epileptogenic focus, as we've been saying, when other methods are non-congruent, and this happens in about 25% of patients assessed for surgery. And also, in some cases, when the epileptogenic zone is close to functional cortex, then to do function mapping to identify areas which are functionally relevant and should not be removed. So overall, when the non-invasive tests are not congruent, then we need to find a hypothesis that we can explain the incongruencies and then tested it with intracranial recordings. So we need a hypothesis to test when we implant electrodes. And this takes us to what procedures and protocols we have for intracranial recordings. Essentially, we have two big aspects, two big protocols. One is what is called subacute or chronic recordings, or electrocorticography. Subacute or chronic. In this case, we implant the electrodes in the theater, and then we wake up the patients with electrodes implanted, take them to the ward, and record seizures and interictal recordings under no anesthesia. The other alternative protocol, which is of course not exclusive, you can use both, is at the time of resection, then to record in the theater acutely for a few minutes the ECG, the electrocorticography, with electrodes on top of the surface, on the surface of the cortex. And of course, this will be mainly studied interictal recordings, and usually it's under general anesthesia, although it can be recorded under local anesthesia. So which protocol shall we use? What electrodes shall we implant, and when? This, of course, depends on the facilities available for each center, the nature of the divergence of the non-invasive test, where we suspect the epileptogenic zone is, or either more than one, we suspect more than one where they are, and whether these are accessible to electrodes. The most, probably the one considered the least invasive intracranial electrode was what developed by Visa many years ago, the foramen ovale electrode. This is an electrode implanted through the foramen ovale, which is of course a natural hole in the skull, and it lies between the brainstem and the hippocampus. And We've studied many patients with this technique in the past at King's, but we found there were quite a lot of side effects. So we decided not to continue with that in the late 90s, and we haven't used them for many years now. The next electrodes that can be used are, of course, mat electrodes and strip electrodes. So either an array of electrodes or a strip of electrodes. Of course, each disc, metallic disc that you can see in the photograph, is one electrode and is connected through wires along this bundle to the corresponding connector. And that, of course, means that each of these electrodes or each pair of electrodes can produce a channel on the EEG. So the strips usually come either in 4 or 8 contacts, and they can be used to assess the orbital cortex and the surface of the temporal lobe and also the hippocampus. They can be implanted through a burr hole, and they can be quite effective in recording. We have also, of course, the mats we've seen on the photograph. These require a craniotomy, and of course they can be combined with strips as well. One of the advantages of the mats is that can be used very effectively to do functional mapping. So you can just stimulate through contiguous contacts and for a few seconds and see what the semiology of the stimulation, what the consequence of the stimulation is. We'll go into that some more detail later on in the talk. There's another modality of electrodes, depth electrodes or intracerebral electrodes. These are wires implanted through the brain into the hippocampus or in different structures in the frontal lobe. And you can see in this photograph, each of these little cylinders is an electrode. And of course, it can record the EEG. And usually the deepest contacts in this temporal approach, lateral approach, would be at the hippocampus or amygdala. The depth electrodes are implanted either through stereotactic frames, like in this case, or through the neuronavigators. Regardless, it has to go through a small borehole into the target structure in the brain. And these are typical implantations. Obviously, not everyone a patient will have all these implantations. It depends where we think the epileptogenic zone is located. And once you have the electrodes implanted and connected to the amplifiers and to the recording system, then we have to interpret them. And intracranial recordings are relatively easy in some aspects, but difficult in others. They are much closer to the sources, so they are high sensitivity. The amplitude of the EEG is about between 3 and 5 times larger than on the scalp. And of course, it has less artifacts, hardly any muscle artifacts. But it has the problem of spatial aliasing. So you can cover a region, a relatively small region, very well, but large regions of the cortex of the brain cannot be sampled because, of course, you cannot put electrodes everywhere, and therefore sometimes are very difficult to interpret, as we will see. The interictal recordings, interictal discharges, are much sharper than on the scalp. They are much larger, they're more frequent, and often you have several patterns independently occurring in different regions, even in different hemispheres, as we see in this recording. So you can see some focal spikes here, another focal sharp waves there, and some other more widespread discharges that if you expand in time, you will see that sometimes these widespread discharges, sometimes bilateral. If you expand them in time, you see that some regions are leading others. And therefore, these discharges probably are arising from the leading sites. And then, of course, if you do chronic recordings, you will also record seizures. This is an interictal recording of one patient, and later on in time, the patient has a seizure. This is the onset, very clear, focal spike and wave, then later on spreads to other regions. The interpretation can be complicated because you have too much detail in a way. This is a seizure starting in this area on the left anterior frontal region, and then later on the seizure stops there, or at least the spike wave stops there and appears somewhere else contralateral to this region. So you have to be very aware that if you didn't have an electrode perhaps here or there, you might not see this bit. Or if you didn't have electrodes here, you might think the onset is on the right, when in fact it's on the left. So we have to be aware of this limitation. And the other problem is the seizure onset can have many manifestations. So here we have a seizure starting with fast activity at about 20 hertz, very focal, very rhythmic, that then spreads to other regions. This is another pattern that you can see as part of seizure onset. A diffuse flattening of the EEG, what we call an electrodecremental event, diffuse flattening of the EEG, the amplitude of the EEG decreases, usually very widespread or even bilateral. And sometimes, focally, you see fast activity. So we usually consider that this is the onset. And in some cases, as we will see later, this is all preceded by a single epileptiform discharge, which is often more widespread than this onset. Sometimes you have a diffuse flattening of the EEG, an electrodecremental event, as the first manifestation of the EEG, of the seizure. And sometimes you have seizures starting with clear spike and wave activity, or even delta, sharpened delta activity that then changes in frequency as it spreads to neighboring contacts. So the onset can be very complicated and is also easy to miss. This is a seizure starting with a run of spikes, very sharp spikes. So we have all these type of seizure onset, and the question that we addressed several years ago is the seizure onset pattern. Does it have any predictive value for surgical outcome? Which patterns are those that will tell us that we are closest to the epileptogenic zone and therefore we should remove them? And we found that fast activity is probably the one. Fast activity and spike wave activity has a high chance of being linked to good outcome. In other words, if you have a seizure starting with fast activity or with spike wave activity and you remove that region, then it's likely that the patient does well. On the contrary, if a seizure starts with a diffused electrodecremental event, even if it has some fast activity, then the outcome decreases. The proportion of good outcome decreases from 75% to 40 or even 8%. So we think that probably the best patterns to identify and to tell us that the electrodes are in the right place are fast activity and spike wave activity. And all the others are more dubious. The other question is, of course, why so many seizures have this preceding epileptiform discharge, a single discharge, just before the onset of the seizure. This is interesting because often this discharge is different from the standard interictal activity in that patient, and it's very common. In our series, we had 75% of patients had this preceding discharge, just preceding the onset of the seizures. In 13%, it was focal, okay, but in 47% and in 16% was even widespread, affecting more than one lobe, or even bilateral. Does that have any say on the outcome? If you have a widespread bilateral discharge at the beginning of the seizure, even if the onset, the fast activity is focal, will that mean the patient will be doing worse after surgery, less seizure control? And we found that this is not the case, or not clearly the case. Patients who had widespread preceding epileptiform discharge or even bilateral discharges can do about 50% of them to actually very well become seizure-free after surgery. So this is an interesting finding, and traditionally when we see this preceding discharge, we ignore it. And these areas tell us that probably that is the right thing to do. Complications of intracranial recordings. What you would expect. Transmission of diseases. This is avoided obviously by disposing of the used electrodes. MATs are implanted through craniotomy. So because the craniotomy remains somehow open for a while we're recording, there is a risk of CSF leakage, which can be minimized by keeping the head high and changing the bandage regularly. Infection is rare. Subdural hematoma has been described, but is also rare. And I mean, frank meningitis and encephalitis is very rare. Depth electrodes have a small risk of infection like the others, and also a small risk of hemorrhage with transitory deficits, about 2%, and hemorrhage with permanent deficits is very uncommon, less than 1%. Function mapping. This is the other application of intracranial recordings. Identify the areas which are functionally relevant if the epileptogenic zone is close to them. And for those in the world of intracranial recordings, we use a very simple technique, which is to stimulate the cortex for several seconds. As you see in this picture, here we are stimulating the cortex for about 4 or 5 seconds. And we use pairs of electrodes, contiguous electrodes, to stimulate. And of course, then we have to be looking at the patient. If the patient moves the hand, it means we're stimulating the area that moves the hand. If the patient describes tingling in the hand, that means we are in the somatosensory cortex for the hand, and we are stimulating that place. Because we know we're stimulating, then we can localize. Sometimes we get what we call after discharges, which are like brief seizures produced by stimulation. And that is not what we want to do. That's a byproduct, but sometimes I will see it can be useful. So essentially, we can stimulate different regions and record or observe the response of the patient. Sometimes the response is a positive response, a movement, twitching of the face, twitching of the hand, or tonic posturing of the hand. Sometimes is sensation, tingling, visual hallucinations, that is subjective. And sometimes is speech arrest. When we stimulate Broca's area, Wernicke's area, then the patient stops either producing speech or understanding it. So we have several types of signs: positive signs, paresthesis, movements, visual or auditory hallucinations; negative signs, numbness, speech arrest. That will tell us where this that we are stimulating a functional area. We see the responses. I must say, when you stimulate most areas, you don't get any response, because most areas in the cortex are not functionally relevant to that degree. Sometimes you get post-discharges, after discharges. And then we have to be careful, because if we get a response, it could be through the propagation of discharges. And sometimes, this is very useful sometimes, we can induce epileptic seizures, proper epileptic seizures. And if these seizures are similar to the patient's habitual seizures, or is the same aura, then that tells us that where we're stimulating is very close to the area that originates these seizures. And for speech mapping, of course, we have to have the patient carrying out a functional speech function that is arrested by the stimulation. We can also stimulate. This is very interesting. We developed it at King's years ago. We can also stimulate with one single pulse and record the EEG, the response, to the stimulation. So these flat channels are the ones used for stimulation. This is the pulse artifact, and this is the response. So most places produce, most sites in the cortex produce an early response, something that looks like this when you stimulate. And other areas produce a delayed response, a spike or a spike wave discharge delayed several milliseconds, more than 100 milliseconds after the artifact, after the stimulus. And we find that these delayed responses are a hallmark, particularly in temporal lobe epilepsy, for the epileptogenic cortex. And this is another example of a delayed response. So this is stimulation artifact, and you get a spike and wave afterwards with a delay, or sometimes a run of spike and wave. Research applications, of course, we have electrodes inside the brain in close contact with the cortex. So we should take this opportunity to carry out research. It's, of course, a unique opportunity. Very few conditions allow you to do that. We studied the connections of different parts of the cortex with space, with single pulses. Of course, you stimulate in this area. Around that area, you will get an early response. But sometimes, even on the other side, you get a response. So that means what you stimulated is actually connected to the area far away, where you also get a response. And if you map it, we found, and these are the thickest and widest arrows, the most reliable or most common connections. We found that there are very strong connections between medial frontal cortex and the contralateral medial frontal cortex, and also between medial frontal cortex and contralateral orbital cortex, and also between both orbital cortices. So the anterior and medial aspect of the temporal lobe is very much connected with the contralateral side, and these connections were usually bidirectional. So that explains why some patients with frontal lobe epilepsy show generalized discharges or secondarily generalized discharges. The other interesting, another example of interesting research was this project we did studying the effect of single pulses on memory, particularly when stimulating the hippocampus. So this is the control condition. You present items periodically, memory items of faces, words, things that the patient has to remember. And about 10 minutes later, you show you make a recognition test and establish how many of these items that you presented are recognized. That's a standard procedure similar to the standard Amityville test. But we also did this stimulating the hippocampus at the time of presenting the items and see how that affects memory. And that's very interesting because what we found, and this is the control condition with no stimulus, is in red, that's control. So when you stimulate the non-epileptic hippocampus or the epileptic hippocampus, more or less the performance is similar to control, there's no effect. When you stimulate the right or the left hippocampus, again, the performance in memory is very similar to control, no stimulus. But when you stimulate both hippocampi at the same time, there's a big drop in memory function. And that obviously suggests that memory is stored in both hippocampi, but independently. Because in order to affect it, then you need to block both hippocampi, not one. When you block one, the other one can perform. The other protocol, of course, is acute electrocorticography. So this is the recording of the EEG on the surface of the cortex during resection. This is a somehow historical picture with Professor Binney and Professor Polke, my mentors and teachers, when we were doing still paper recordings in the theater, and people are wearing masks not because of coronavirus, but because we are recording with the EEG machine in the operating theater. And again, you get rather complex waveforms, different discharges with different topography, some more widespread, some more focal, even in the same page. And the question is, how do you interpret this? And there are different schools, of course, but in my experience, apart from many several factors that have been described as a good or poor prognostic sign, in my experience is you should remove the spikes unless they are in the insula or in the margins of the resection. So the procedures that you do in EKG, then you do a resection, then in the theater still do another recording. If you have spikes in the margins of the resection, that's probably no problem. It's just produced by the resection. But if they're farther away, that means that some of the epileptogenic zone might have been left behind. Sometimes you get something like this, a very widespread discharge. If you expand it in time, you find that some areas are leading the others. So it's these areas that you need to remove, the ones that are leading the discharge, because probably these are the triggers for the discharge, and the discharge later propagates through the connections. In the frontal lobe, of course, you can have sporadic discharges, like in this case, but another finding that you often see is interictal continuous spiking, or nearly continuous spiking, or burst of spikes, usually focal. This is the hallmark of focal cortical dysplasia, which of course is a common pathology in frontal lobe epilepsy, particularly in children. So when you see these discharges on the acute EKG, you need to remove them. Otherwise, seizures will continue after surgery. So this takes us to the practicalities of recordings. So we said that when we do pre-surgical assessment, we end up with a number of tests which are non-congruent, and therefore that means that we need to explain why they're not congruent, and you end up with questions or hypotheses of why these are not congruent. So the typical questions are the question of laterality, and that, in other words, you know the patient has temporal lobe epilepsy, or less frequently frontal lobe epilepsy, frontal lobe seizures or temporal lobe seizures, but you don't know from what side they're coming. And the other question is that of localization, which is you more or less think because of head rotation or whatever, you can know that that the seizures are coming from the right or from the left, but you're not sure if it's temporal or extratemporal. So these questions need to be addressed with clear hypothesis to be tested by the implantation of electrodes, which is of course limited. You cannot implant everywhere. So let's look at an example. This is a lady that came to us at the age of 28, right-handed female, and she had her pregnancy was normal delivery, full term, normal schooling. Started nursing at the university, which she didn't finish because of depression she didn't finish because of depression and fits. There's no family history of epilepsy or neurological conditions. No history of febrile convulsions, meningitis, or encephalitis. So the only pathology, the only abnormality in the history is repeated infections that led to hearing deficits, and now she's wearing hearing aid. But at the age of 5, she started to have seizures. And these seizures were there were two types. There were clusters of simple partial seizures consisting of a rising sensation in the stomach up, and she would average about 6 per week. And the second type occurred usually out of sleep. The patient would wake up when asleep. She would wake up with an aura of deja vu, And then she would lose consciousness, sit up, become restless, fidgety. She might moan, looked around, fiddle with things, a typical complex partial seizures, and she was able to speak afterwards, straight away. So again, that recovery of speech, fast recovery of speech, would suggest a right hemisphere onset. She would sometimes have forced head rotation to the left, and then secondarily generalized convulsions. And again, that would suggest a right hemisphere onset. And she would average about 2 of these more severe seizures per week. She was put on anticonvulsants, and she went through several regimes which were ineffective. The neuropsychology was normal and remarkable, normal IQ, verbal and nonverbal IQ. The EEG showed diffuse slowing, mild slowing, probably due to the medication, and sharpish components were seen over the right temporal region. She had a scalp telemetry and had 2 simple partial seizures and 2 complex partial seizures, which with a right anterior to mid-temporal onset. So we were making this hypothesis of a right temporal epileptogenic zone, which would have been all right so far. But then the MRI showed multiple lesions, cortical thickening resembling focal cortical dysplasia, but multiple lesions, and of course that would suggest tuberous sclerosis. So she was diagnosed with tuberous sclerosis, and indeed you can see several tubers, one left mid-frontal, one right frontal, one and the biggest right temporal, which remember is our main candidate for the seizures, right temporal, a big tuber there. And some suprasylvian, right suprasylvian lesion. So we had a clear hypothesis that we had probably temporal epilepsy arising from the right hemisphere. But we had several lesions, so we decided to implant in many of these lesions to prove that it is the right temporal lesion that is producing the seizures. And then if that is the case, a single epileptogenic zone, then to remove it. So we implanted electrodes in different regions, in different of these lesions, in several of these lesions, and we had several, of course, epileptiform discharges. This is the interictal record. And remember that the right anterior temporal electrode will have several contacts. Right anterior temporal, right posterior temporal, contacts 1 and 2 are the deepest. So in each of them, so they will be at the hippocampus, anterior, posterior hippocampus, and you can see these focal spikes in the right posterior hippocampus, fairly frequent, and some of them would spread to the remaining of the temporal contacts on the right. And she had several seizures, many of these auras of deja vu, of rising epigastric sensation, and they were associated with these very clear, fairly widespread but restricted to the temporal lobe, right temporal discharges, lasting for a few seconds when she was reporting an aura. And she had 2 or 3 seizures, complex partial seizures, and these showed a very clear, clear onset in the right hippocampus. Remember, if you go back to the slides of MRI, the right hippocampus is fairly normal. The tuber, the lesion, is lateral temporal. But here we have lesions, seizures, which arise from the right hippocampus, which is structurally apparently normal. So this is what I was saying before, that we need to use functional techniques and also structural techniques to identify the epileptogenic zone. Because in this case, as I've seen several occasions, a lesion that is lateral to the hippocampus is associated with seizures arising from the hippocampus. So you have to remove the lesion and also the hippocampus on the same side. So this patient had a right temporal lobectomy, and because we thought that all seizures arose from the temporal lobe, some more crisp, some more widespread, we removed the lesion. So the lobectomy, which was in principle standard, was farther back, was extended farther back to because of the lesion, and the patient has been seizure-free for 2 years. So just to clarify and to make the concrete points, and the final message is that intracranial recordings are useful in presurgical assessment when non-invasive tests are incongruent. We need to have a clear implantation strategy, a hypothesis that we need to test for each patient. And therefore, that means the implantation tends to be non-standard because many patients are very different. So the intracranial recordings are much less standard than the scalp EEG recordings. And you need experience to identify and interpret the patterns that you can see on intracranial recordings, often more complex than you can see on the scalp, because essentially you have more information and you're closer to the sources. And very important, intracranial recordings provide a unique opportunity to do research that you cannot do anywhere else in any other scenario into the brain and on the pathophysiology of epilepsy. Thank you very much.
Of all EEG intracranial recordings. We have several questions from the audience that I would like to address now. So Pedro Sudbrak tell us it's a great talk, and he asks, regarding mapping for epileptogenic zones close to the motor cortex, does it make sense to search for movement arrest in addition to involuntary movements following electrical stimulation?
In my experience, I've never seen movement arrest. Of course, to check for movement arrest, you have to have the patient moving something, doing some motor function. Otherwise, you won't be able to see arrest. And that's not something that I've used as a standard protocol. So I've never used that approach. But it seems to me, from my experience, that the motor, the positive signs, the motor positive signs are more than enough for motor function and for sensory function, but not, of course, for speech. Speech is manifested by the opposite, by speech arrest, deficit in function. And sometimes the most common sensation when you stimulate the somatosensory cortex, the most common sensation you evoke is tingling. Sometimes pain, sometimes a burning sensation, usually tingling, and occasionally numbness, which you can say that is a negative sign. But for motor mapping, usually motor positive signs are enough. I've never used the other approach.
Professor Alarcón, can you stop sharing the screen, please? Richard is asking us.
Yeah. Thank
you. Then we have another question from Charlie Garcia. He says, hello, many thanks for the webinar. He has a query. When a patient with epilepsy has electrical stimulation on the epileptogenic area, would we see a large response on the EEG?
Not necessarily. You're talking a large response to single pulses. usually you don't get particularly large response. What you get is a delayed response. So somehow a loop that should be inhibited and suppressed is not suppressed. And when you stimulate that one area, after a few milliseconds, you get a second response, sometimes a third response. So that tells you that the loops which should be suppressed, inhibited, are not. And that is what is essentially a seizure. A repeated spike and wave.
Perfect. Now we have another question. It's from Yamile. She says, is there any correlation between non-clinical seizures during intracranial recordings and post-surgical seizure freedom? Yes.
So clinical seizures.
Subclinical
Yes.
seizures, yes.
Yes. Non-clinical seizures or clinical seizures. So electrographic seizures. So seizures which are seen on the EEG but are not associated with any manifestations. Often, if they are focal, they also highlight the epileptogenic zone. So it's a good marker for the epileptogenic zone. And of course, if you see them, we should remove them. You should remove them if you see them. On the scalp, then of course the problem is that you don't do intracranial recordings afterwards, so you don't know if the subclinical seizures remained or did not remain, because they, by definition, have no semiology. So you don't know. For that, you need to do intracranial recordings again, which we don't, unless you see them on the scalp, which is unusual. Yes. But the main point is that this is clinical seizures. When they are focal, they have the same value as the clinical seizures for localizing the epileptogenic zone.
Perfect. We have another question. Why the responses to single pulse electrical stimulation you showed us on the presentation were little? I was expecting to see huge responses as epileptic cortex is meant to be hyperexcitable.
Yes, yeah, that's right. That's what you would expect. That's what I expected initially when we developed the technique, but it's not the case. Maybe there's a slightly bigger, but they are more or less the same amplitude. But what happens is that we've done, I didn't show this data, but you can read it in my paper from 2012 on single cell recording. So when you do stimulation, when you stimulate the cortex, actually many cells are suppressed because of lateral inhibition. So there's an initial 100 milliseconds of activity. I'm talking about action potentials. There's a burst of action potentials in the beginning, and then many cells are suppressed for about 300 or 400 milliseconds or 700 milliseconds. So most of the response you see to single pulse is actually inhibition. It's not activity, it's suppression produced by the initial activity. So what tells you that that cortex is epileptogenic is not whether the seizure, the response is much bigger or smaller, is whether the response, which is mainly inhibition, can suppress further responses, or can suppress the loops involved in reverberating activity. And that means that if it doesn't, you will see a delay response, maybe a second or third delay response. So the hallmark of epileptogenicity in the response of single pulse is the duration of the responses, or the repetition of the discharge of the responses, rather than the amplitude. Often the responses resemble very much the interictal activity. So they're not much bigger than interictal activity. They are the same, but they last for longer, because the loops involved in reverberating activity in producing a seizure are not suppressed in the area where seizures arise. That's why the patient is having seizures.
Perfect. We have another question. Are we expecting to see seizure freedom in a patient with different seizure types?
Yes, if they are coming from the same place. For instance, in the example, this patient had two types of seizures, obviously compatible with the epileptogenic zone, but essentially two types of auras. One was rising sensation, the other one was deja vu, both compatible with temporal lobe epilepsy, but different. So probably had two seizure types arising from the same lobe. And if that is the case, when you remove the lobe, you can render the patient seizure-free. But it has to be, if there are different seizure types, you have to be able to explain why they might be coming from the same place, both in terms of semiology and in terms of electroencephalography. And that will be the question to address to implant the electrodes.
Perfect. What is the meaning of after discharges? What can we learn when stimulating the patient and we find after discharges?
Yes, after discharges, I think is just a small seizure, usually a brief seizure, produced by the long stimulation using function mapping. So the problem is, as you know, seizures can arise anywhere in the cortex. And so you think an area is epileptogenic, not only because it can produce seizures, because the threshold for seizures is lower there than anywhere else. So given enough stimulation or stress, you can induce seizures anywhere. So when you get after discharges, you are just inducing a seizure by the stimulation because you're using high intensity, because the area, for instance, is non-functional, so there's no response. So you keep increasing the intensity until you get a response. If you go beyond 10 or 12 milliamps, then you're likely to produce a seizure. So if the seizure is the habitual seizure, let's say the same aura as the patient has, then that has a very strong localizing value. That means you've been stimulating the epileptogenic zone because you have induced a seizure which is similar to the habitual seizures of that patient. If not, if the after discharge or the seizure that you induced by the stimulation is different or asymptomatic, or is different from the habitual seizures, then it has no particular value to localize. But you have to be careful. If you produce a movement with after discharges, then you have to be careful and look at the distribution of after discharges, because the movement might have been produced not by your stimulation, but by the after discharges, which can propagate to other regions. So this is what I meant by being cautious when you have a patient with after discharges. The semiology, if you induce any semiology, motor manifestations or speech arrest, might have been induced by the after discharges propagating, not necessarily by your stimulation.
Perfect.
And of course, it means if you have to record after discharges, record the EEG to see after discharges, because if you induce after discharges, of course, I didn't explain so much detail, but the intensity of stimulation at each site is increased gradually until you get either the response or after discharges. If you see after discharges, you shouldn't increase the intensity anymore, because you can produce severe seizures or even status. So you're stimulating in a place, you produce after discharges, there's no response, then you move to another place.
Correct. Perfect. Thank you for this amazing talk. I think we learned a lot, and it was very comprehensive. We could understand many things about the intracranial recordings and their indications and how to proceed with them. So thank you so much for for being with us today. And thank you very much for the audience for the wonderful questions and for participating today in our webinar. Thank you so much.
Be my pleasure. Thank you very much.